This week on the BackTable podcast.
You form a friendship to begin with, and it has worked so far. For example, when I first met President Obama, he was a senator. And at one of the political dinners, he was sitting next to me. After hearing him speak, both on the podium and chit-chat at the dinner table, I said, "Barack, you should run for president. You'd make a very good president." He said, "Come on, KJ. I just got here, a senator, haven't even got my ears wet, and ran the program that he should run and he will win, and I make him sign it." So I still have that piece of paper.
Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Now, a quick word from our sponsor. Hi, friends and colleagues. We're thrilled to announce the launch of BackTable Plus for ENT. BackTable Plus features bite-sized learning modules created by ENTs for ENTs. The content is designed to be searchable, organized, and easy to digest, making it perfect for our busy schedules. Best of all, it's completely free. We encourage you to explore the platform and share your thoughts with us. Go to plus.backtable.com, plus.backtable.com, and click on ENT courses. Your feedback is invaluable as we strive to make this resource as beneficial as possible. Happy learning, and we can't wait to hear what you think. Now, back to the show.
Hey, everybody. Welcome to the BackTable ENT podcast. My name's Ashley Agan, and we've got a really great show for you today. I'm joined, luckily today, by the lovely Dr. Gopi Shah.
How are you, Ash?
Hey, I'm great. How are you doing?
I'm so excited because I think we have a otolaryngology legend with us today, so super honored. Should I go ahead and introduce him?
Yes, please.
All right. So we have Dr. KJ Lee. He's a world-renowned otolaryngologist, a clinician, educator, author, innovator, and health policy advisor. Many of us know Dr. Lee from his book, Essential Otolaryngology, Head Neck Surgery. However, he has also been at the forefront of healthcare, creating technologies that simplify physician workflow and ensuring government mandates do not hinder patient care. In 2004, he sponsored the bipartisan Presidential Healthcare Summit in conjunction with the Center for Congressional and Presidential Studies at the American University. He has advised United States presidential candidates and members of Congress on health policy. And he is here with us to talk about otolaryngologists as a political leader. Welcome to the show, Dr. Lee.
Thank you.
We're so excited to have you.
Thank you. Well, although otolaryngologists constitute a very small percentage of all the doctors in this country, yet somehow otolaryngologists are very active and prominent in medical politics and politics in general. And because of that, we are able to advocate for our patients what they need to members of Congress and the president.
Dr. Lee, can you tell us a little bit about how you got into policy and advocacy? Like, was it something that was during your medical training or in your practice that influenced your entry?
Not really. I stay active first locally in Connecticut with the members of Congress, with the governor and governor's office, and just be humble, simple, and just try to not lecture to them, but talk to them as a colleague, as a friend, what patients need. Patients need good outcome. We all want good outcome. Patients need the care being rendered with great compassion. Patient wants the doctors and nurses to listen to their problem. And if there are any procedure to be done, patients want to know why this procedure, the pros and the cons, because every procedure has a side effect. But mainly we can enumerate all these, but basically to listen to the patient. Then from the practical standpoint, what the patient like, such as you, is when you call for an appointment, the phone system is user-friendly, not being passed from prompt to prompt. You want a human person to answer your phone, and after a short conversation, give you an appointment appropriate to your condition. If it is an emergency, the doctor should make time to see the patient that day. If it is urgent but not an emergency, the doctor should to see the patient within a week, a few days. And if it is completely elective, then you can wait. When I try to tell doctors and nurses what I'm saying, or to lay people, it's very hard to define the word compassion. It's like beauty. How do you define beauty? Okay? So therefore, with the help of a businessman from Asia, we founded an organization, nonprofit organization, called TPIU. We stand for the patient is you. So how do you define compassion? How you would like to be treated as a patient. You can do that. The answer is so in front of you. And that's what I've been advocating all this time. Okay?
Yeah, it's like that golden rule about, treating others the way you'd like to be treated, right?
Rule.
We learn that when we're really small and we forget it sometimes along the way.
Dr. Lee, is that something that you feel like in medical education or training is something that's teachable? Like, how do we become more compassionate or have more empathy towards our patients?
I think it's more teachable maybe 10, 20 years ago. Now, it is even more important to impart this knowledge because medicine now becomes corporate and all they look for is the bottom line. And because of that, it becomes very difficult for patients to navigate the system and the costs keep escalating. Now, there are many examples I can give you why the costs keep escalating. But one simple one I can mention now in the interest of time. When an institution buys a physician's practice, or the physician who's independent now becomes an employee of an institution, when the bill goes out, let's say the consultation is $100. So a bill goes out for $100. In addition, the institution add on what they call facility fee. And the facility fee is usually about 1.5 times the physician's fee. So as an example, if the physician fee is $100, the facility fee is $150. So now the patient or the insurance company, whoever is paying the tab, has to pay $250. And that physician is seeing that patient in the same examining room as before, the same chair, the same stethoscope, the same blood pressure. Why add this quote-unquote facility fee? Okay? So I try to do supportive of local politicians. That's how I got started. And all politicians need money. So usually they have a reception in which you contribute. And I contribute willingly and freely and get to know the politician well, so they will trust me, hopefully, and then go on from there. And I usually start with the young, new politician because they are more eager to learn. Once you become the president of the United States, it's very hard to approach them. And instead of a contribution of $10,000, if you're going to do the same impact with the president of the United States, you'll be more like $200,000 or even higher. So I'm trying to impart the knowledge to otolaryngologists as a political leader.
So Dr. Lee, many young people that are starting out 5 to 10 years in their practice, they may say, well, I'm just so busy in my practice. How does creating relationships with my local politicians help me or help my practice or help my patients overall? How do you answer that question?
The way I would answer it, you got to look at the long term, okay? And no matter how busy you are, if something is important, you can always find time to do that. Now, the other thing I've noticed, and I apologize for mentioning it, that nowadays the physician, when they say no time, that means they don't want to work harder. They want to go home early, and so on and so forth. So they can always make time, okay? Like, for example, and I'm not holier than thou, when I was practicing before I retired, I would see patient to about 5 o'clock, and if there's an emergency or urgent add-on, make it 6 o'clock. And then after that, I do all these politics things with them. So it's a matter of, are you willing to put in the time for your own future? And they do listen. They do listen.
Just reflecting on your journey, when you started developing relationships with your local politicians, what sort of things did you see where you were able to maybe help make change? Because I think sometimes the barrier for getting people involved is just a feeling that it's not going to matter. I'm going to put forth all this effort to try to lobby or talk to politicians, but, things don't change. And so do you recall along your journey, examples of things you were able to help make changes for the better?
Yeah, I think they do listen. And when somebody high up makes a statement or write an email to an insurance company, the insurance company pay more attention than one from a doctor. It's a synergy working together. It's not a straight line.
In terms of the otolaryngologists, is there a special perspective that we as otolaryngologists bring, or as surgical specialists, or that you found that you were able to bring during your journey in advocacy and policy?
Well, somehow, as I said, otolaryngologists constitute a small percentage of all the doctors, and yet they are much more interested in this than other specialties. For example, the 2 AMA presidents, AMA represent all the doctors, so to say. 2 consecutive presidents are otolaryngologists.
Do you think there's something about us as otolaryngologists that we just tend to naturally gravitate towards leadership positions?
I can't tell you why, but it so happened that otolaryngologists are somehow very active, interested, and effective in influencing policies. Our executive vice president, CEO of the Academy of Otolaryngology Hand and Neck Surgery, he's an ENT doctor, but he doesn't practice anymore. He runs the academy and in charge of all these policy situations, and he's very effective, very insightful. Too bad he's retiring, okay, at the end of the year. But I'm sure the next one that we've already appointed Dr. Shah to be this succeeding CEO, will do even better.
So in 2020, you wrote that we need to be kinder and gentler. What do you mean by that? And do you think that we as Americans are kinder and gentler than we were in 2020? Are we moving in the right direction? Are these teachable qualities?
Wow, you really dig into what I've learned. Good for you. Yeah. Well, but by saying that we should be kinder and gentler does not imply we are not, okay? But there's always room for improvement. And for example, is that let's say you're on the highway and somebody cuts you off. Don't get mad. Go ahead. What's the difference? 5 seconds? 10 seconds? If you're in a supermarket and somebody's shopping cart accidentally cut you off, I say, no problem. You go first. So if we have this thinking process, the world will be a happier place, more gentler, and you then don't get all upset, which means you get to live longer too.
It's kind of like the OR board, right? You have another add-on, a case, and something comes in, and you just have to say, it's okay, that there's another case that might proceed or preclude or have to go ahead of mine. So I feel like from the grocery store to, traffic to any of it, it applies in our day-to-day. Dr. Lee, in that same, for our listeners, the article or the reference, the writing that we're referring to, there's a great 2020 otolaryngologist as a political leader in the North American clinics, and we'll put that in our show notes. In that piece, you wrote about 8 items that could help fix our healthcare system. If you could pick one, which one is the most important thing at this time that we could improve or change?
I would say that the most important is to practice TPIU. Once you practice that, the rest, whether it is pain, cost, or anything, very simple. What would you like if you were the patient? And we all doctors should do that.
And with your TPIU foundation, tell us more about how, through that foundation, how you're trying to make changes to healthcare.
Well, we have our mission statement, we have our to-do list, and if you're interested, after we hang up, I can have all those documents sent to you. It's to publication, to the doctors, to, I hate to say teach the doctors, implying they don't know that. Is more to bring them, they all know that, is to bring all these ideas to the forefront of their thinking.
What do you think the biggest barrier is for physicians if we feel like that the solution is just to treat the patient as you would want to be treated? What do you think the barrier is for physicians treating the patient as they would want to be?
I want to make sure I couch my words correctly. The hesitation is that perhaps this generation of physicians coming out look more towards their own leisure time. There's only 24 hours of the day. So to spend more time in TPIU, it takes time. That means you go home later, you eat your dinner at 9 o'clock instead of 6 o'clock, and so on and so forth.
And do you think that the declining reimbursement, the challenges of taking care of patients when the math just doesn't add up, for example, if it costs more to take care of patients, but you're getting reimbursed less. So in order to make the math work, you're seeing more patients per day. And as you said, there's only 24 hours in a day. I feel, when I'm talking to colleagues that's, one of the big pain points for people is trying to make the math work, right?
It doesn't take that much more time to practice TPIU. It is the attitude, the listening, and if the patient were in the office, not Zoom, the placing of your hand on the shoulder in a diplomatic, proper way, that exude is a body language that carry the TPIU message.
Do you feel like there's ever a barrier to really embody or practice TPIU from a systems level? I mean, one example you gave is having a human being, somebody that when they call your office, there's somebody that can talk to the patient. So that first interaction, sometimes it's when they're talking to the front desk, the scheduler, to whether it's interfacing with your website. Do you feel like any of those factors can be enhanced to also make the patient is you sort of that empathy, like what are my pain points, whether it's me as a patient and I'm trying to navigate my own, healthcare with the physician, whether it's the MyChart system to being able to talk to somebody, getting a phone call back. How do you think of it on a systems level?
I think it has to be somebody at a very high level to change it, okay? And that person who high level would to be have all phones have a human answer. And don't go around, which means it costs more, okay? But that's okay if you want to have TPIU care. Right now, if you call a certain hospital and you just know your symptoms, you don't even know what kind of doctor to look for, you get passed from prompt to prompt. And then at the end of it, sometimes they say, go to MyChart. So now you have to go to MyChart, okay? MyChart sounds very good. So somebody, a PR person called it right, make it more personal. But it's not. It's just to farm you away so you don't have to talk to the human or human talk to you. You could and you put your question in MyChart, and X number of days later, you may get an answer, but not by a human again, by another male or whatever. So you go on and on. Now, if you have a tooth abscess, painful, you can't wait for that. It all boils down to put profit behind. First, care for patient first. pretending we are running an old-fashioned missionary hospital in Malaysia, where I grew up. That missionary hospital is not looking at how much money they make. They put money in there. There's the missionary hospital. I think it's all boiled down, and I apologize for saying that. Sounds like I'm criticizing the young doctor, is that your patient comes before you.
Can you tell us a little bit more about your time growing up in Malaysia and the exposure that you had to a missionary hospital there?
Well, I was in high school, so when I got sick, I'm a high school kid, not even an adult. And all the nurses, and there's only 2 doctors, small missionary, are very TPIU. Yeah, they don't look at me as this high school kid complainer. Yeah, so again, I don't know how to put it. It's not a formula. It's not a chemistry. It is what is in your heart. Now, dial back to the day a pre-med is being interviewed for med school. And all of them that I know of, they say, why do you want to become a doctor? And the answer is TPIU. I want to care for people. I want to help them. Very good. But what happened between that interview and the day they finish medical school or finish residency? What happened? Okay. Again, I'm going to give you just an example because it's hard to define TPIU. At 5 o'clock Friday afternoon, the phone rang and the doctors, the resident in one room finishing up their paperwork, and a patient has a car accident and facial fracture. It should be all the 10 residents sitting there, I'll take care of it. But if you were sitting in that conference room with me, it's the opposite. Oh, you go. I got a dinner date. I got a movie ticket. Yeah. So it's completely opposite when they were interviewing for medical school. I want to take care of people. Versus, I want to do my thing. It's prestigious to be a doctor, makes money or whatever you do. But when 5 o'clock comes, 6 o'clock to take care of a facial fracture, you go instead of volunteer to go. I can't say anything more than that without sounding hypercritical.
And so, the whole concept, the patient is you. When you're talking to politicians, either your local or national politicians about fixing the healthcare system with kind of this foundation of the patient is you, what kind of pushback do you get when you tell them, we need to put the patient first regardless of the cost? Because someone's always thinking about the price tag, right? So what kind of pushback do you get when you say, well, regardless of cost, we need to have humans answering the phone. We need to, do whatever we can to make the patient the priority?
I think the politicians I talk to are very supportive there. I don't see very pushback. And what I don't understand, and maybe you can educate me, is why is TPIU, practice like TPIU cost more? It shouldn't be cost more. Why would it cost more?
I mean, like, for example, earlier we talked about how hiring someone to answer the phone costs more, but that that shouldn't matter because that improves the patient experience. So things like that.
Well, my friend, a business person, is sitting here. Maybe she can help me answer that. The question you ask doesn't compute with me. You just do what is right. Period. PIU, the patient is you. Yeah.
When you do start to getting to know some of the community leaders or the politicians in your community, and you mentioned really starting with the ones that are younger, newer, coming in, maybe that's the time to kind of plant those roots and start forming those relationships. How do you decide or know sort of which candidate or that you want to support or create those relationships with? Is it more based on, do you know already what their ideas are, or how do you kind of position yourself to align with a good political member or team to really sort of push what you want, push TPIU and get that to the forefront?
I don't have a checklist of who I support. It's whoever wants to listen, and you form a friendship to begin with. And it has worked so far. Like, for example, when I first met President Obama, he was a senator. And at one of the political dinners, he was sitting next to me, and he just became a senator. And after hearing him speak, both on the podium and chit-chat at the dinner table, I said, Barack, you should run for president. You make a very good president. He said, come on, KJ. I just got here, a senator, haven't even got my ears wet, and I took out the program paper, because I have no paper, and ran the program that he should run and he will win, and I make him sign it. So I still have that piece of paper, okay? So it is a matter of just getting to know people, see how they feel, and how it goes.
Well, in your article, there's lots of pictures of you with, some of the politicians that you've known and worked with over the years, including President Obama. Any other memorable stories from along the way?
Well, I spent a lot of time with Hillary Clinton also, and now Rosa DeLauro. So, yeah. And Governor Lamont. And in fact, Governor Lamont proclaimed July 10th, TPIU Day of Connecticut. And the Lieutenant Governor, Susan Bysiewicz. Yeah.
Congratulations. Have an official day.
I think be genuine and make friends first, that's all. And there's nothing in my agenda for me. It's the agenda for TPIU. Treat the patient as you learn, that's all.
Yeah, I feel like there's a lot of day-to-day opportunities for specific to TPIU. Sometimes it's intentional, right? You have to be really intentional until it maybe becomes more of a practice or behavior change, or that's majority of how it works, so that the reaction, right, or the proactive action of when things pop up, right, the 6 p.m. consult, the automatic is the TPIU mindset, right? I feel like the other thing that might be interesting is, we do have, like, when you think about academic departments and, didactics and conferences, there's, quality and improvement and, other ways, but maybe the TPIU lens is something, or that maybe could be more emphasized, or, just like we are trying to, I feel like, get a little bit more of a health equity lens when we talk about whether it's at M&M conference to, other conference days. And like you said, it's top down. So it's something that once we continue to kind of keep bringing it up and keep sort of showing why it's important and setting an example, it really is a culture, I think, a culture shift or culture change.
Well, besides essential otolaryngology, which you all know about,
I used edition 8, by the way, Dr. Lee. The 8th edition that's how I passed my boards.
I've come up with a series since our specialty has specialized. So I have essential facial plastic, essential otology, and essential pediatric otology. Just came out last month.
That's awesome, because there's a complex PEDS board exam now. So that would be a great one to, use potentially. I'll have to check out the Essential Peds Oto.
Yeah, you go to Nova Publisher, and they would have the list of all these new books that I've come up with. And since we're talking a little bit about economics, the latest one that just came out is on essential, rational healthcare economics.
Ooh, I bet that's a good one. I think, on that topic, there's been a lot of discussion about quality in healthcare and how to measure quality. How do you decide what quality is and which physicians are providing quality? Can you speak a little bit to how you think about that? How do we incentivize and reward quality healthcare?
At the last chapter of this healthcare economics book, we tried to come out with a hybrid payment system. Hybrid payment system is not perfect yet. So I put that for people like you to fine-tune it, is that there'll be patient questionnaire to evaluate the doctor. And when you do a procedure or whatever, without question, you will be paid X percentage right away. So this way, it helps how our bills are being delayed, rejected, and so on and so forth. So X percent, and you can put the X percentage at 60%. Okay, not 100%, obviously, 60%. And then the rest depends on how good a steward of your healthcare dollar. And then need, again, computer to monitor you. For example, everybody who comes in with a sore throat and you happen to own a CT scan in your office, now another ENT doctor has that mini CAT scan. So everybody comes in with a sore throat and an earache, get a CAT scan, right? That will make you not a good steward of the healthcare dollars. So if we can have that combination, pay you some upfront so you can cover your office costs, and the rest to reward you if you are a good steward of the healthcare dollars. It's too long to describe right here. It's easy if you read it on that last chapter of that book. And that last chapter, Ask for Help, has a skeleton, but then ask for help, and it'd be very good if two of you can look at it, help us all out.
Yeah, I struggle because with a couple of things. So healthcare increasingly is more like a service industry. Like, there's a lot of customer service. So for example, patients may request certain testing or imaging that according to the guidelines is not indicated. But because we want to have a higher Press Ganey score, or we want a 5-star Google review, we might acquiesce and order the scan even though maybe it wasn't indicated. Or the circumstances where you order a scan that maybe you otherwise wouldn't have, and then you find something, you find a cancer that was incidental and ended up being life-saving because you found it earlier. And I think these things change our practice a little bit, and sometimes it's hard to align that with practice guidelines and, being good stewards of healthcare dollars. It's just something I think about and struggle with a little bit.
Yeah, you're right. It's very complicated and complex. I like to use the word complex rather than complicated. Complicated meaning something that's not right. But you're right. Healthcare, you are taking care of a human being with emotions and some non-tangible. You're absolutely right. Yeah. Like, for example, you're absolutely right. A patient has a lot of cardiac type symptoms and was bounced from pillar to post in Florida, and the husband knows me and consulted me. So I introduced her to Yale's Executive Health. Yale has recently launched an Executive Health, complicated cases from all over the world. And in the helping her with a breathing problem, with a cardiac problem, and pulmonary problem, they saw a little shadow, and they followed through. It's incidental finding. Happens to be breast carcinoma. And it's so small because you just incidental finding. They removed it with good margins so that she got cured of a potential cancer before it actually develops. You're right. But then, do we put everybody through a PET scan? Well, yeah, it's very complex, very complex. And I'm glad the two of you are thinking about this and carry on this. Yeah, I'm close to 100 years old, so I won't be around for too long. But you two go on for another 50 years.
Dr. Lee, how do you see is the big difference between patient satisfaction and practicing TPIU? How do you kind of think about those two things? And how are they similar and how are they different?
You want somebody to answer the phone. You want to have an appointment, soon, but relative to your symptoms. And the doctor talk to you, listen to you, body language and words, and follow through. And if you have a test done, as soon as the results come in, you should notify the patient rather than wait, X number of days or weeks sometimes. Yeah. You're right. It's very hard to define that. And so that's why I came up with TPIU. I say, no matter what your question is, what would you want if you were the patient?
The patient may or may not always be satisfied. I would imagine that if you are practicing TPIU, probably for the most part, at the end of the day, hopefully everybody's on the same page because communication and, helping your patient understand the decisions that you guys are making together will help you get the outcomes you both are happy with and what's best for the patient. But there probably are times where maybe the, quote, patient satisfaction, the Google review, all this sort of noise, right? The external metrics that whether we agree with them or think or not, they're there, may not always be, there's probably a small percentage. And that's okay, I would imagine.
Oh, yeah, you're right. You can't please all the people all the time. And there will be certain patients, then no matter what you do, are unhappy. And we have a label for them, too. We call them XX patient. In the days of the old paper chart, in the corner, we wrote down XX. So
just a little signal.
Just something, to set up your expectations.
Well,
okay.
We're all human. We're all human.
Yeah, we're all human.
Dr. Lee, you've had an amazing career. Looking back, can you talk to us about, maybe your greatest challenge or what you're most proud of, just thinking about what you've accomplished?
I don't want to use the word proud of. What I'm most happy with is that unless I'm blinded, then I have a very happy patient. I can walk down, Stop and Shop, okay, and very common. I get stopped. Dr. Lee, you treated me for XYZ. You operated on me. Now that I'm getting old and a little unsteady in my walking, I go to exercise classes. And the exercise classes is not one-on-one. It is a whole bunch of people. I would say once a week, I go there 3 times a week. Once a week, somebody will come back. And these are old people, because these are old people getting exercise. So, Dr. Lee, you operated on me X number of years ago, and I'm so happy. And I get this in church, in supermarket, in exercise class. I think that is the most rewarding. Not the money I make. That is the most rewarding. I used to call it TPIU, meaning the patient is you. Our keynote speaker for our first gala, the actor Michael Douglas, that's why he's a famous guy, he called it TPIU. The you, he called it us. The patient is us. It sounds even better than patient is you.
It does.
Yeah.
It sounds good. Dr. Lee, as we start to round it out, are there any final words or pearls or anything that you're most hopeful for, anything like that you want to leave our listeners with?
I would just ask whoever listened to it, give a little thought that is not onerous to treat patients as if the patient is us. That's all. It can be done. Doesn't take much time, doesn't take whatever. It can be done. Just slow down and go back to practice what you told the interviewer when you been interviewed to get into medical school. Just remember that.
Thank you so much.
Yeah, thank you so much. What an honor.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.